Thank you so much, Chairperson, for kind introduction. Thank you, Bansi Sabu sir, for inviting me here again and DiaObecon. So last in the series, something about the asymptomatic hyperuricemia. We know everybody knows about the symptomatic hyperuricemia, what is the treatment, but today we'll discuss something about whether we have to treat or not the asymptomatic hyperuricemia. So we know that it's a very common disorder that affects patients of all ages and the genders, and most common manifestation is gout and uric acid nephrolithiasis. Asymptomatic means there is only uric acid is elevated, but there is no disease, no gout or no uric acid renal disease, and urate lowering therapy initiated in cases of symptomatic, but the frequent condition of asymptomatic hyperuricemia remains a challenge for all of us. This is the prevalence where that 21% of general population is having a asymptomatic hyperuricemia, and while hospitalized patient is 25%, means every fourth patient will have the increased level of uric acids. And in India and across the country, it's increasing now day by day. It was almost 25% till 2018 data. So normal serum uric acid level in men and women on postmenopausal, it's about 3.5 to 7 milligram per deciliter. In premenopausal, it's a little bit lower, and the crystallization occurs if it is more than 6.8. It can be classified if it is symptoms are there in terms of gout and the nephrolithiasis. Asymptomatic, there is only uric acid is increased. This is important slide, how the uric acid level production there. It's a whether it's a dietary purines, endogenous or exogenous, there is a tissue nucleic acid which gives us the urate. So there are two mechanisms. One there is a overproduction of uric acid that can be occur some clinical conditions, like we know that there is a obesity, the diabetes, high cell turnover and tumor lysis syndromes, Down syndrome, tissue ischemia and hypoxia. There are some genetic disorders where maybe some gene deficiency, there may be some gene superactivity. A few of glycogen storage disease also will have increased uric acid levels. Diet, of course, the seafood, meats, vegetables, fructose, vitamins and alcohol. Alcohol is having both the mechanism. There is overproduction of uric acid and same as well the under excretion of the uric acid. So some under excretion uric acid clinical disorders are the renal impairment, volume depletion, obesity and small bowel disease. Again, the genetic disorders also there, the Euromodulin variants, the glomerulocystic disease, diet, ethanol and fructose. So we are concerned about that there is an increased uric acid level, but what it does, it causes chronic kidney disease, atherosclerosis, stroke, gout, hypertension and cardiovascular disease. There are some drugs also which can induce the under excretion of uric acid, like calcineurin, the levodopa, and some drugs causes more production of uric acid level like the cytotoxic agents. The causes exogenous and endogenous, where we can see that purine goes to the xanthine, and by activation of xanthine oxidase there is a uric acid which goes to 30% to the gut and 70% to the kidney. So absence of uric acid, additional genetic variants, thiazides and loop diuretics, they basically increase the purine productions. Complications of hyperuricemia, gout. Daily increasing day by day the gout cases with age and with the degree of hyperuricemia. If uric acid more, then there may be a chances to getting the gout is more. Urolithiasis, now it's increasing 0.01 to 2%, very large range. And uric acid nephropathy is such a tumor lysis syndrome patient where the lymphoproliferative disorders, you may have an acute kidney injury along with the uric acid nephropathy. This is something controversial, complications of hyperuricemia, where we know that hyperuricemia can cause the severe disease, but stroke, renal disease, the diabetes, hypertension, they are both, they can cause the asymptomatic hyperuricemia, and hyperuricemia asymptomatic can cause the both the diseases. Asymptomatic hyperuricemia, there are some metabolic disorders which is prevalent by increasing uric acid levels, and both vice versa. It is more than 1.6 times increased risk of developing metabolic syndrome who are having a increased level of uric acid. In cardiovascular disease, this is also associated with increased risk of developing hypertension in following 5 years, regardless of other risk factors, and it is also closely related with the hyperuricemia relative risk of 1.13. If uric acid level is more than 7 milligram per deciliter, then multiply the risk of ESRD by 4 in men and 10 in women. The other epidemiological studies have confirmed that increasing serum urate levels are associated with the impaired ESRD, including EGFR. I'll show you some studies which are done to show the hyperuricemia. So this is an Indian study where the 47% of those patients who had a hyperuricemia, they presented with the hypertension as compared to the 37% of normouricemic patient. So the percentage of hyperuricemia increases significantly in India's obese population. This is another Japanese cohort study which was followed for 5 years, and in that they have seen that the asymptomatic hyperuricemia without any comorbidities predicts the cardiovascular metabolic disease, and the results was say that the increase for developing hypertension, dyslipidemia, obesity and CKD, and a non-significant trend for developing the diabetes mellitus. So if we are getting all these diseases, very long cohort, they are suggesting that we have to treat the asymptomatic hyperuricemia. This is another study where only the monosodium urate levels deposits were associated with the severe coronary artery calcification in asymptomatic hyperuricemia, and the prevalence of moderate to severe was significantly higher in patients with asymptomatic hyperuricemia along with the monosodium urate crystals compared with the patients where asymptomatic hyperuricemia alone and patients with the normouricemia. Again, this study which was published in the Clinical Journal of American Society of Nephrology, and the study was whether the uric acid have role in ARF. Yes, the study told us that it is not only a marker but also may contribute the pathogenically to the renal vasoconstrictions as well as to the endothelial dysfunctions, inflammatory response, oxidative stress and disturbance in the autoregulation, that all leads to the acute renal failure. The role of asymptomatic hyperuricemia in the progression of CKD and CV disease. If there are high levels, they can cause the kidney damage through the crystal dependent and non-crystal dependent mechanism, which include the inflammation, oxidative stress and the hemodynamic alterations. So those who are having asymptomatic hyperuricemia, this is a silent activator through the innate immunity, through the inflammation, through the oxidative stress also. This is again European review for association between the asymptomatic hyperuricemia and the knee osteoarthritis in the older people. We all know that as age advances, there is an increased chances of osteoarthritis. But asymptomatic hyperuricemia was very common among older OPD patients with the knee osteoarthritis in comparison to the normouricemia. Then again, the uric acid levels and the mortality. This was a very large nationwide community-based cohort in the Japan, and they have shown the results that there is a significant increase in the risk of all-cause and cardiovascular mortality was observed in men with if serum uric acid level was more than 7 and less than 3, and in women with more than 5 levels. So the asymptomatic hyperuricemia as an independent risk factor for myocardial infarction, it was again a very long cohort for 4 years follow-up study, and they come up with that there is an increased risk of non-fatal myocardial infarctions even in the absence of traditional risk factors which we used to see in the outlife of the CV, like smoking, hypertension, diabetes and many more. So even if they are not there and there the uric acid level is raised, we should think about to treat that one. So accumulating all evidences suggests that asymptomatic hyperuricemia contributes to the comorbidity with which it associates with the proper asymptomatic hyperuricemia, and treatment may reduce the future risk of developing all the CV diseases. So although there are clear recommendations on the treatment of gout with urate lowering therapy, but the management of asymptomatic hyperuricemia remains the controversial. So let's see, this is again a very important slide. There was idea consensus statement, and they have said that if asymptomatic hyperuricemia means uric acid level if it is more than 6.8, start the first non-pharmacological therapy, dietary restrictions, moderate exercise and weight reductions, avoiding and modifying drugs causing the hyperuricemia. Still, if there is a uric acid level between 6.8 to 8.9, go for a renal functions. If renal functions are normal, no urate lowering therapy, because this will solve all your queries. If there is a CKD stage 3 or more, then start the urate lowering therapy. If serum uric acid more than 9, don't think, just go for a urate lowering therapy. So these again are the papers from various recommendations, and they have said the efficacy and urate lowering safety of agents in asymptomatic hyperuricemia. They said that the composite renal events and EGFR, by treating the allopurinol, they are the renoprotective effects in hyperuricemic patients. So this again a study which shows the effects of uric acid lowering therapy and progression of CKD. So if we start the uric acid lowering therapy in asymptomatic hyperuricemia, then we can retard the fall in EGFR in treatment arm. So again, subgroup analysis will show the whether it is allopurinol or febuxostate. So if we are giving in asymptomatic hyperuria patient the allopurinol, that will reduce your significant decrease in systolic blood pressure also, whether patient was on antihypertensive drugs or not being administered. So to summarize regarding the treatment, people with asymptomatic hyperuricemia are at increased risk of cardiometabolic disease. Lowering uric acid therapy may play an important role in delaying the progression. Non-pharmacological treatment with diet restrictions and exercise is recommended for all patients who are asymptomatic hyperuricemia. Also, low-dose urate lowering therapy should be initiated in patients to mitigate the complications. So given all the renal, cardiovascular and cerebrovascular benefits from normalizing serum uric acid level with urate lowering therapy, now the question is not that whether we have to treat. Now the question is that when we have to start, rather we have to ask when we have to start the patient on urate lowering therapy. Thank you everyone.